Started with the panel. Thank you. So I am really honored to moderate this panel today. I'm a reporter at the Los Angeles Times where I write about health. And I'm really passionate about these issues, about health disparities and the intersection between public health and poverty. And I spend a lot of my time writing about these issues. And we see them, as we know, we see the disparities in access to doctors, quality of hospitals, prevalence of chronic disease like asthma and diabetes. And as a journalist, I feel like it's my role to write about these issues in a really personal way, to hold policymakers accountable, but also to highlight the work of people who are trying to address them and trying to eliminate these disparities. And that's where our panel comes in. They are on the front lines working incredibly hard every day to try to reduce these gaps and to try to improve the health outcomes of some of the most vulnerable populations in California. So please look at the detailed bios in your packet, and I'll just say just one word or two about each of our panelists as we get started. Ms. Cynthia Harding is the Chief Deputy Director of the LA County Department of Public Health, where she has been there for nearly 30 years working on maternal and child health, AIDS prevention, and tobacco control. Beatrice Solis is the Director of Healthy Communities at the California Endowment, where she works on developing healthy neighborhoods up and down the state. You've already heard all about our Dean of the UCLA Fielding School of Public Health. And Dr. Bill Pitkin is the Director of Domestic Programs for the Conrad N. Hilton Foundation, where he fights to reduce chronic homelessness and poverty. So we're going to jump right in with questions. I'm going to start it off with a handful of questions, and then we're going to open it up to the audience, and we'll have two folks walking around with microphones ready to take your questions. So please be thinking of things you might want to ask our panelists. Cynthia, we're going to start with you. Health disparities, as we know, can begin long before babies are even born, and when they're born too soon. Can you talk a little bit about how doctors and public health leaders are trying to improve generational outcomes by beginning health promotion even before conception?
Yes, good afternoon. Thank you, Anna. It's my pleasure to be here at part of this symposium on today's panel, and it's a great question, and one which I'm going to use an example from our work in maternal child health to begin to answer. So, you know, in the 20th century, one of the number one strategies to reduce infant mortality was to get women into early prenatal care. And throughout the 20th century, we saw rates of infant mortality decreasing. Towards the end of that century, we begin to see a plateauing of the rates of infant mortality. But more disturbingly is that we continue to see a huge gap in the infant mortality rates between African Americans that continue today to die at babies continue to die at 2 to 3 times the rate of other racial and ethnic groups. And even though we were able to reduce the infant mortality rates, we weren't able to reduce that disparity. So across the country in the early 2000s through 2005, my colleagues across the country began to meet and discuss what are things that we can do to address this disturbing disparity in infant mortality rates. And more and more that work led us to think about the health of women before they got pregnant and the role of stress, and the stress plays the role of disparate treatment and how that plays out in birth outcomes. So I want to tell a quick story about work we did in 2004 when we were addressing an alarmingly high rate of infant mortality in the Antelope Valley, where we were looking at rates of African American babies dying at 5 to 6 times the rate of the rest of the county. And while the numbers were small in the Antelope Valley, so that can mean that the rates can be somewhat volatile, we were still looking at a real disparity in infant mortality outcomes. And there's a couple of lessons that we learned as a health department. We worked with our community providers to address that disturbing rise in infant mortality. And one of it was that we needed to have the right kind of data to address this issue, not just the traditional data that we got from looking at health records and vital records, but also the data that we got from going out and speaking to women in the community. And when we looked at the traditional data, it showed us that these babies were being born too soon and not weighing enough. and that many of the women declared that they had not, these were not planned pregnancies. But then when we went out to talk to the women themselves, they said, number one, transportation was a huge issue for them. I don't know if you've been up in the Antelope Valley, but it's easy to get back and forth between the valley if you're traveling into Los Angeles for work in the morning and going back in the evening. But if you want to get from one side of the valley to the other, sort of like your story in Tanzania, you have to, the transportation is not very good to get across the valley. They said, when we go in to see providers, they're not taking our health concerns seriously. And when we go in to see providers, we're being treated as if we're single welfare moms, regardless of our marital status and regardless of our income status. So there was a number of issues that we heard from women in our work up there. And then we talked to providers, and providers said, when women come to us, even if they come in early prenatal care, if they've come with a series of underlying health conditions, we can't solve that in 9 months of pregnancy. And even if we're able to refer women to high-risk care, if they can't get there, we can't solve that problem. So there were a number of issues that rose in the data, traditional data that we looked at, and also this non-traditional data, speaking with the people up there. And we convened a number of community forums, bringing together people in the community to talk about and discuss this data with us. And as a result, we were able to get our hospital providers and others to work with us on better discharge planning, on looking at ways to serve and link women to resources postpartum, to support breastfeeding, and to talk about infant safety. And with them, we worked with our Black Infant Health Program up in that area, a program which specifically addresses the issue of high infant mortality among African Americans and links women to resources up there. It's all over the county, but we had a specific program up in the Antelope Valley, and they brought in a series of church leaders to that forum that we had. And it was those religious leaders that got up and said, we want to be part of the solution. We've got vans. So during the day, we're going to help with this transportation issue. Not only are we going to help get women to appointments, but we're going to also help get them to job training and other resources after the baby's born. And I said, I need you to do one other thing, and that's to link women to family planning. Because if these babies are being born, these are unplanned pregnancies, we want to make sure that we give women access to resources. If you're pregnant, let's get you in the Black Infant Health Program. If you're not pregnant, let's get you into family planning. So this sort of led us to understanding, a greater understanding that our programs needed to focus on this life course perspective, not just about one woman, one time, but a broader perspective. And in order to have successful birth outcomes, we needed to have healthy women. And in order to have healthy women, we needed to have healthy communities. And so it was our Black Infant Health Program working with others in the community to bring them together to solve this problem. It wasn't us by ourselves or one agency by themselves, but a partnership of agencies coming together to address the data and to look at what we could do together. And it brings me to talk just really briefly about one program that we have that's a life course approach and looking at how we change the next generation and the interventions that we do. And it's our Nurse Family Partnership Program, a program which serves young first-time women living in poverty. And the program tries to counteract what can often be a spiraling down into poverty with teen pregnancy, helping those women, they see the women while they're pregnant and then follow them until the baby turns 2 years old. And it has incredible outcomes for the mother as it helps her get back into the workforce and to get back into school off of welfare, but it also has incredible outcomes for the child. So when we look at, and the program's been evaluated for 30 plus years, but when we look at the outcomes for children, those children are much better and ready for school. Those children are much more likely to graduate from high school and have less contact with the criminal justice system. So it's a program that works and serves several generations. But it doesn't just stop there. It's when those nurse-family partnership, when that program, when those nurses that are serving and working with folks in the community then begin to work with community agencies and look at the conditions in which people are living, the physical and social environments in which they live, and partner with family resource centers and gang prevention agencies and civic organizations to look at how we together can work to improve the environments in which people live.
Thank you. Bill, let's turn to you. You've worked hard to improve the outcomes for homeless people. I want to start you off with two quick questions. First, why are homeless individuals so medically vulnerable? And second, how has the Housing First movement and the increase in special housing for chronically ill homeless people helped improve health outcomes among this population?
Thank you. It's a pleasure to be here. I feel a bit like an outsider. Not because I'm the only male up here. I'm used to that. I work in the philanthropic nonprofit sector, but I think I'm the only one without a public health degree, which speaks to, I think, a little bit of some of the solutions. So my background is in urban planning and housing, and just want to talk a little bit about just the big picture on homelessness, just to give you the big picture on that. So in the U.S., we have about 630,000 homeless people every night, according to the last count. About 100,000 of those are what we call chronically homeless, long-term homeless, be homeless for a year or more, or have 4 episodes of homelessness within the last year. And they're among the most vulnerable people, certainly in our society. And I would say, too, to the dean, that's another UN agreement, the right to shelter and housing that this country has not signed on to. So we have in Los Angeles County about 50,000 homeless people every night, and a higher rate of chronic homelessness, about 24%, 25%, so about 12,000 chronically homeless people according to the last count. Obviously, the health needs are vital amongst the population. On the one hand, health disabilities and vulnerabilities can be causes of homelessness, so mental illness, substance abuse disorder, physical ailments, but certainly being homeless is not very good for your health either. Exposure, frostbite in cold climates, skin and wound infections, those are the kinds of things that clinics report. Communicable diseases, if people are in shelter with lots of people who aren't getting access to health care, have low levels of nutrition. There are a number of studies that have shown that the mortality rate for homeless people in the U.S. is 3 to 4 times that of the general U.S. population. So again, homelessness is not good for your health. And I would say there's some urgency if you look at the demographics of the homeless population. There's probably the best known researcher in the homelessness area is a guy by the name of Dennis Culhane at the University of Pennsylvania. He was profiled in an article 2006, I believe, in the New Yorker by Malcolm Gladwell, and who profiled his research, and it was subtitled "Why It's Easier to Solve Homelessness Than to Manage It." The article is called $1 Million Murray, and it profiles a gentleman named Murray Barr in Reno, who they estimated cost the local systems $1 million over. Was a chronic alcoholic and spent many years on the streets. Dennis's latest research, and if you're a consumer of NPR, you may have heard this a couple months ago. There was a story by a health reporter on some of his research on the demographics and aging of the homeless population, which certainly mirrors the demographics of our population. But what he's found is that the average age has moved throughout time, and has some really interesting charts, which they actually included in the article on the NPR website, that show that the average age of the chronic homeless population has moved throughout time. And he finds that half of the chronic homeless population are late age baby boomers, born between 1955 and 64, that came of age during a time of a couple of recessions, time of the crack cocaine epidemic, etc. And they've been homeless for a very long time. And certainly, in our overall health system, that's going to create issues. This is a very needy and vulnerable population that is going to need long-term care. And the good news is that we know it works. There's a high cost to doing nothing, both for these individuals and for society as a whole. You asked about Housing First. Housing First is an approach to provide housing. It seems so simple, but for a long time, we as a society have tried to treat the problem rather than solve it. This model that we call permanent supportive housing basically marries permanent housing, not just emergency shelter or transitional shelter, permanent housing with no time limits, with services, be they health, mental health, substance abuse treatment, etc., job training, whatever services that they need. And dozens of studies have shown that this approach, if implemented correctly, even though it's costly, is cost neutral or can even save money in the long run. In recent research in Los Angeles, for example, it showed that people before these chronically homeless people, many living on the streets or cycling in and of shelters and jails, were costing our local systems about $35,000 on average, $35,000 a year. Most of that in healthcare costs. After being housed, that went down. Even accounting for the cost of providing permanent housing went down by 40%. A number of studies have shown this. There's an interesting study in Seattle that's been profiled in JAMA and the American Journal of Public Health, looking at people who are chronic alcoholics and been given housing, that they do better, they save taxpayers money, et cetera. I want to just highlight real quickly one project that we've been working on here in Los Angeles with a partner, the Corporation for Supportive Housing. It's targeting frequent users of our local health systems. It's called the Frequent User System Engagement Project, and it's gotten started off with philanthropic funds and also has attracted federal funds through the Social Innovation Fund. They have 7 partnerships throughout the county, from the West Side to Hollywood, South LA, downtown, San Fernando Valley, Glendale, and Pasadena. And they partner up a local hospital or maybe a couple hospitals with a community clinic, an FQHC, and housing navigators, a housing organization. And they identify the most costly, needy people coming out of those systems, those in the top 10%, the top decile, who on average cost about $80,000 a year. And I just got some recent data. There's about, it's a really demonstration project that they've gotten federal funds for, also working on projects in Michigan and Connecticut and up in San Francisco. But in LA, there are about 140 people that have been enrolled. The average age is 49. And these people, their average number of ER visits over a year is more than 6 times. An average of more than 10 days in inpatient days in hospitals. 88% have chronic physical disabilities, and about 2/3 have a mental illness or a substance use disorder. They looked at two of these hospitals are participating in this process, in this project, and compared the 12 months before housing and the 12 months after getting housing in terms of the hospital's costs that they were incurring. They found that just in these 2 hospitals, about 34 cases, the number of ER visits and inpatient stays went down by an average of over 2/3. So, for example, the average number of ER visits went down from 6 to 2, and the number of inpatient days went down from 10 to 2. The average cost went down from $17,000 for the hospital to $5,000. So I think this is an approach that works, and we continue to work with our partners to implement it, the financing. But again, doing nothing costs us a lot, and I think it's summarized by a button I got at a conference that housing is healthcare.
Wonderful. Thank you, Bill. It sounds like there's more attention. It sounds like there's a lot more attention being paid to the homeless population by both groups like your own and academics and hospitals, and everybody's realizing that there's a cost to them and to society if we don't do something. Let's turn to Beatrice. The California Endowment, our hosts today, is very involved with the implementation of the health reform law, which takes full effect on January 1st. With undocumented immigrants being excluded from health reform, how prepared is the safety net here in California to continue providing them with both the primary and emergency care that they may need?
Thank you, Anna. We're at a really unique moment in history. On the one hand, we have the Affordable Care Act and everyone running to implementation, and at the same time, the Senate passed their version of the immigration bill. So we have these really 2 momentous things that are happening that are unprecedented, and I would say the most important issues to care about in California. We recently worked with Manuel Pastor to look at a study in terms of looking at regions in California on the number of immigrants and number of undocumented. When you begin to look at those particular numbers, it becomes really clear, and it was really clear for us at the California Endowment, that it's something that you have to pay attention to. So, for example, some key findings were that the immigrant population in California, there's this perception that they're very mobile. Well, in reality, if you look at in LA, again, with their study, they found that they've been residing here for 10 years or more. They're buying homes. There's mixed status families. So parents, maybe one or both parents are undocumented, but their children are U.S. born. California, compared to the rest of the country, we're a complete outlier in terms of that, of what I just mentioned, in terms of residing here in place for more than 10 years. When we look at the demographic shift, and I'll just point out, we have Boyle Heights that's here, it's 95% Latino. But if we look and think about South LA, that transition in terms of immigrants there has shifted significantly from in the 1990s, it was Latinos composed 60% of the population, and from 2005 to 2009, it's 78. So we see that there's a major shift in population that's happening here in our great county. The other big thing that we're learning is that when we think about mixed status families, the systems that we have set up currently, even if we think of Covered California, undocumented or not able to purchase coverage, there is great confusion about, and again, I'm assuming folks know about the exchange, which is, again, set up through the Affordable Care Act, where each state would have a marketplace for those that can afford, that are above certain poverty thresholds, that don't have health coverage through their employer, are able to purchase a plan through this, Travelocity type of website or system that they're setting. But part of the problem is that if you are a parent that is undocumented and you have a child that's a citizen and you don't, navigating of how you would purchase, it's still really unclear in terms of how they will be able to get coverage. When we think about kids in LA County, the number of kids in mixed status family, it's over 1.5 million. That's an estimate. So we're thinking about young children. We're releasing a study pretty soon. It's a health impact assessment looking at the connection of these children in mixed status families and mental health and social supports. So it really paints a clear picture that U.S.-born kids to mixed status families, again, U.S.-born, I underscore that they're high levels of fear, high levels of PTSD, high levels of not sure where to go to the doctor. And, I don't have to convince this group here. I mean, we've all been inoculated with the problems of the lack of health insurance. If you don't have health insurance, you're not going to go for preventive care because of the out-of-pocket expenses are sometimes too high. And we know the benefits of having health coverage in that at minimum you do get those preventive visits. Your outcomes, if it's a major chronic illness, will be taken care of. So we know that for these families in LA County that are mixed status, that they're not going to get care. One, because of the public charge issue, and I know for those of us that have worked on issues of immigration last time around, it's a really big issue, which basically means that folks are worried that if they take on public benefits, that it will impact their ability to receive legal status. And with the way the current immigration bill reads, there is fear that, yes, you can lose it. So losing, again, applying for health insurance for their child, even if there's this ounce of insecurity about it, they're not going to apply because, again, they will not be able to get their legal status. So there's a lot of confusion. So I wanted to paint that landscape because it's critically important for us as public health folks to really realize this is the moment to lift up your voice. And, taking from Francine's point, it's a real campaign about how California in particular is, uniquely positioned. I mean, because when we look at the numbers overall, we do have much higher numbers of immigrants overall. But in terms of what can be done in terms of the safety net, again, it's another critical issue. Our governor, you know, we have a controlled Democratic Assembly, Senate. I mean, we have a Democratic governor, but we don't have Medi-Cal expansion. You know, how do we explain that? Two, we know that the fees from licensing, and I can't recall what else, have really been discretionary, not discretionary, but funds that come to the county to be able to provide those safety net services for the remaining uninsured, for undocumented, for those that don't have coverage. And so now there's a big tussle around this realignment where the governor wants to essentially take those funds from counties and disperse them in other areas, which will be catastrophic for LA County. I mean, again, you think about the numbers, you think about just basic healthcare services, that no one else will take care of these folks. It is the county social safety net. So I would say right now we're in a really difficult situation. And I know that Mitch Katz, you know, the chief for Department of Health and Services here in LA County, has been ringing that bell quite loudly, that there has to be more movement on ensuring that counties, especially with high numbers of undocumented or remaining uninsured, because again, some folks will not see a benefit to purchasing from the exchange. So when something happens in life, they will need to receive care. So that's there are advocates in the state that are really pushing for mediation so that for a minimum of 3 years, because healthcare reform hasn't been implemented fully yet, that why not, rather than having the governor just make that decision, why not wait 3 years? And with those 3 years, then begin to reduce the amount of those funds providing support and coverage through the safety net. So I would say we don't have an answer right now. I know people are tinkering at the edges around trying to find and develop an insurance product for the remaining uninsured. There's some FQHCs like El Proyecto del Barrio that's in San Fernando Valley that has sort of a low-cost program, but again, it's sort of tinkering at the edges and not a complete solution.
And I know there's a lot of fear that we're just not going to be ready by January 1st. Dean, let me ask you a question about civic engagement. Can you talk a little bit about what role civic engagement plays in improving the health of vulnerable populations, and what more can be done to get these traditionally disenfranchised groups involved in helping their communities become healthier, and the workforce that you're training, how can they help with this as well?
So, not sure, is this on?
Yep.
No? Okay, there we go. Let me talk about two different kinds of civic engagement. One is the civic engagement that happens around changing the whole policy context. That might be changing what Bea just talked to us about. Who gets insurance? Is immigration law in contrast to what's going on with the ACA? And the other is the kind of civic engagement that I think we heard in what both Cynthia and Bill were talking about, which is when do we hear from people who are affected directly about what's affecting them? So I'll start with that latter kind. I don't think we ask often enough, and we've been committed in our work. I know many of the people who are here are committed in their work, and I'm certainly committed as an educational institution to this being a big part of students' lives, that people be in the community hearing the experience when they decide what to do. You heard two, I think, deep examples already, but I'll give one simple one. In that story I told before about women unable to care for their children's essential health needs while keeping a job and putting food on the table, I can't tell you how many times I've been in a forum where someone has suggested parent education. Now, this is not to say parent education is not worthwhile. I'm a parent. I have two wonderful young men as sons now. There were many times, particularly during adolescence, when I would have loved some guidance. I always wondered, why were there a plethora of books about what to do at 0 to 3? And then you hit the teen years, and they completely abandon you. Where's all the advice when you need it? So I'm all for that, and yet that would not address their problems. And as soon as you sit and talk about the real constraints in this same setting in the housing projects, we were talking about the risk of drug use by their children and teen pregnancy, and they say, we know when they're at risk. They're at risk during the after-school hours when nobody's with them and we have to be at work. And sure enough, you look at the data, and that's exactly what it says about when teens are at risk. So I think that's one kind of engagement, hearing the voices. I know one of my first jobs was working with the homeless. One of the things that was very striking when you spoke to people about their experience with the healthcare system is they couldn't get into the hospital. And I'll be surprised if the ACA fully cures that. That's because hospitals don't want to admit someone they can't discharge. And it's very difficult to discharge when you don't have a home. So I think that engagement, hearing by people who are most affected, hearing their ideas is just crucial. The second piece is at this policy level, these changes will only come through all of our civic engagement, the civic engagement of everybody who is directly affected and everyone who believes we should have a system that works towards greater health equity. I think from a school standpoint, we need to get better, and I hope we will get better, at providing the skills, just like I believe actually every university needs to get better at this, at providing the skills people need to really interact successfully with local, state, and national government.
Thank you. Now, I definitely have a few questions of my own, being a reporter, but I think let's open it up to the audience. If folks have questions, we have a couple people with microphones, and please state your name and keep your questions succinct. Go ahead. Right here.
Hi, I'm Paul Simon with the LA County Department of Public Health. There was a really influential Institute of Medicine report that came out earlier this year that demonstrated how much of an outlier our nation is in terms of our longevity and other measures of health related to other economically advantaged countries. We're truly an outlier. And Dr. Heyman, I was actually struck by how much of an outlier we are on a number of these social policies. I wasn't quite aware of that. I'm wondering if you or others on the panel believe that there's a strong connection between the two and what we might do about these, disparate characteristics that we have versus other countries.
Thanks. So the short answer is totally. The slightly longer answer. So for people who, I suspect most people here are aware of the numbers, but for people who aren't, there's a study across advanced economies looking at OECD countries, so North America, Europe, Japan. And what they found is out of 19 countries, the US is ranked number 19th in preventable deaths. So we're at the bottom. By the way, we're getting worse. So we started in the bottom half, and then we've just progressively gotten worse. I think that's very largely a question of social conditions. That's not to say there isn't a part that will be addressed by the ACA and by access. I came to this job most recently from Canada. It's a striking contrast just north of our border. They, like most of the world, spend much less on healthcare than we do. They provide good but imperfect access to healthcare, and if we have time, we can talk in more detail about what that's about. But where they are utterly different is on the social conditions. So if you live in Quebec, you will get early childhood care and education for your children for $7 a day. I don't know about anybody else, but I can tell you that that's a lot less than I paid 20 years ago in the United States, and let alone what people pay now. The university education was $2,000 for the best number one ranked university in the country. When they talked about rising that, the students protested for 100 days in a row and toppled the Quebec government. There is universal health care, but the social compact is entirely different. And the evidence that transforms health risk shows very clearly through the data that people are not getting as sick in the first place.
Thank you. I think we have a question here.
My name is Tim Wright. I'm a RN, a registered nurse, and I have a master's in public health from UCLA and also a PhD in medical anthropology from UCLA.
Great.
But I spent 5 years working as a parish nurse, mostly with homeless people, and mostly right across the street, Our Lady Queen of Angels. So I'm very familiar with working with homeless and trying to find healthcare services. Trying to keep my questions succinct, I could talk for 20 minutes. But I'm really curious about how you think, I'm not sure I'm asking, how you think the Affordable Care Act is going to affect healthcare services available to the homeless specifically. And the reason I'm asking that is because Mitchell Katz was a very big promoter of Healthy Way LA as a sort of transitional way of getting us halfway toward Affordable Care Act. And it turned out, when I worked for Queens Care, it turned out to be very disadvantageous for homeless people because suddenly a lot of preferred poor people became available. They said, wait a second, why should we take homeless who are mentally ill, many of them, alcoholics, many of them, don't keep appointments, are very sick, et cetera, et cetera, et cetera, when we now can get reimbursement for you who live in apartments, they're mentally healthy, and they show up. So there I was with my people coming to see me at the church, and I could see they were very sick, and I could say, well, there's scheduled clinics that we all know about, but I thought there was going to be a huge expansion. And so where are we going?
Bill, why don't you take that?
I can just answer a little. I mean, I think that's a great question. We're very concerned about. I think the advocates and people working in the homelessness world are, they feel like they're just a drop, in Sacramento and trying to get these issues addressed, right? They get support from philanthropy, from us, from the California Endowment, but I think it's so overwhelming, so many challenges with implementation. We have provided some support to clinics here, working with the county to get them on Healthy Way LA for that transition, and hopefully care coordination is the key. I mean, for this person, they need people like you working with them. And I mean, there's also, there are important policy issues. So one of the options in the Affordable Care Act, and again, I'm an urban planner, so the other people are more experts on this, but the health home option is something that can happen at the state level. There is state legislation that's been proposed, AB 361, I think, Holly Mitchell's proposed. I think, and some states are taking advantage of that, and that allows, because that's the tricky thing, how do we pay for these? Part of it's the housing, and we'll try to get the resources for that, but the services and those ongoing services and case management, which is needed so much to help people get from clinic to hospital to wherever they need to be, and there is funding available to make that happen, but there has to be legislation and it has to be signed off by the state. So we are very concerned about it as well. I think there's great opportunity, like in anything, but a lot of concern that with all of the challenges of implementation, that as usual, homeless people's needs are going to be really low down on the priority list.
Thank you. I think we have time for one last question over here.
My name is Mariam Farzanegan, and I was very fortunate to have both roamers as my mentors. I've been working for UNICEF for the past 20 years, and I've lived in 4 continents and worked, God knows, 30, 40 countries. And each time I came back to LA, roamers invited me to their homes, and they educated me and they fed me. I recall one time Ruth also invited 2-3 past presidents of the Public Health Association, APHA, and late Rick Brown was also present. and they discussed U.S. ratification of the Convention on the Right of the Child. And as you know, about 195 countries have ratified the CRC. There are only 3 countries which haven't ratified: Somalia and also South Sudan, which is a very new country, and the United States. And I want to echo to the panel, also to the collective wisdom in this room, what Ruth Romer always asked me: what do we do now? And what's the next step to get
That's a
the
great
US
question.
ratify the Convention on the Right of the Child? Thank you.
Go ahead. Do you want to?
Thank you so much for that, Marianne. And I'm just so glad you raised the CRC. It is dramatic that we haven't signed it. Everybody knows the conditions in Somalia right now. As for South Sudan, they've had a few other things to deal with since they're so new. I mean, we are really totally isolated. Lest one be afraid that there's something really impossible within the CRC to sign, just go take a look. It's about not having child labor, not having child marriage, supporting families, helping children not live in dire conditions. These are all fundamental basic rights that, and it does, absolutely does make a difference on the international stage whether the United States takes a public stand. So my answer to your question about what's next is we should all write our representatives and say, have you thought about signing it? This goes through Congress. What have you done? Write the Senate. Talk to 5 other people and talk to them about it. And maybe if there's enough action where they start to hear this question raised, we'll get some movement.
Thank you. Now, I know we could go on and on. I'm sure there are other questions, but I see that the time has run out. So thank you to the expertise of our panel. And please stick around for just another minute. I'm going to turn the microphone back over to Beatrice. Thank you so much.